Hi everyone, so let's talk a little bit about migraine and the perimenopausal transition. So first of all, what do we call the perimenopausal transition? It's a time frame around menopause where there are cycle irregularities or other menopause-related symptoms such as hot flashes, issues with sleep, vaginal dryness, and sometimes also during that time, they can have loop events, luteal out of phase events, when women ovulate twice in the same cycle, and this actual peaks in estradiol can also be associated with more migraine attack. During this perimenopausal transition, that changes in migraine frequency, severity, semiology, there can be worsening of menstrual migraine, but it's not infrequent to see in my practice. So where migraine present can change a lot from what people used to be used to now. So it's good to see here to discuss and go from there. Migraine is also associated with more frequent and more severe vasomotor symptoms. That's something to take into account. And when we take care of people with migraine, we have to take into account all the comorbidities, including vasomotor symptoms. So there are FDA-approved treatments for vasomotor symptoms, such as systemic hormone therapy, paroxetine salt, and then the newer medication, Vioza and liquids. There are other things that we can do off-label, such as gabapentin, SNRIs such as venlafaxine, desvenlafaxine, SSRIs mentioned paroxetine, escitalopram, citalopram. Some people also find help from cognitive behavioral therapy and hypnosis. It is about 16 to 29% migraine prevalence in menopause. There is this myth going around that there's normal migraine after menopause, which is absolutely not true. About 8 to 13% of women have new onset migraine with menopause. So it's really dependent on the person and the situation. The good news is about 2/3 of women with migraine have an improvement after menopause, especially for women who used to have menstrually related migraine attacks. There tends to be less improvement for migraine with aura, and as far as we know, there's not really a change in migraine frequency with surgical menopause. And as I think I just mentioned, it's very important to address the whole picture in terms of migraine and management, but also addressing all the perimenopausal related changes in mood, cognition, sleep, vasomotor symptoms. So migraine, some frequent question. Migraine is not an indication for systemic menopausal hormone therapy. Indications include moderate to severe vasomotor symptoms, preventing osteoporosis, and early or premature menopause. That being said, it seems like systemic menopausal hormone therapy, especially the frequently prescribed transdermal estradiol with micronized progesterone, seems to help, at least in some women, with migraine during that time, but that's an indirect benefit. That's not indication. We do not prescribe systemic menopausal hormone therapy on the basis of migraine. And from the data we have, it seems like transdermal estrogen does not seem to increase the stroke risk. For women under 60 years old, the absolute stroke risk from menopausal hormone therapy tends to be rare, about 2 additional strokes per 10,000 person years of use. Past or current migraine with aura is not a contraindication to systemic menopausal hormone therapy. We try to use shortest dose for the shortest time, and if possible using transdermal estrogen. And that's because if you don't take estrogen by mouth, you put it transdermal with a patch, for example, that actually bypass the metabolism of estrogen in the GI tract with the liver. And when estrogen is metabolized in the liver, that increase some of the clotting factors. So that's why using it transdermal has less cardiovascular risk. There has been some studies, such as the Oxford Vascular study, that showed no significant association. There's no significant association between menopausal hormone therapy and strokes of unknown cause in people with migraine. There has been another large population-based nested case control study of women between 50 to 79 years old with more than 50,000 women with strokes, matched to more than 59,000 women without stroke, and transdermal estrogen was not associated with increased risk of stroke. Oral estrogen had an association, so we tend to favor transdermal estrogen.